Hi guys, Johnny and Paulina here, and we are looking at the ankle complex, and we're looking at passive range of motion of the talocrural joint. So the talocrural joint is the joint that comprises of the fibula, so the flimsy bone on the outside, your tibia and your medial malleolus on the inside, and then your talus here. So looking at Paulina's ankle, this is the talocrural joint here. Underneath this, we've got the subtalar joint. So this is where the calcaneus and the talus meet each other. So you can see that the talus plays a huge role in these two joints. So you've got your talocrural joint and your subtalar joint. We're also going to look at passive movement of the foot. In particular, we're going to look at flexion and extension. So passive flexion and passive extension of the toes. Okay, so we're going to look at dorsiflexion first. So we're going to bring our toes to our nose, okay? And we're going to look at passive the movements as we go. So this is the distal third of the tibia here. So I'm going to use one hand to fixate there. As you can see, the patient is in long sitting. So what that means is her knees are straight. And what I'm going to do here, again, is I'm going to get my hand and I'm going to just fix it, just nice and easily, on the tibia and fibula here. And then with my other hand, I'm going to put it underneath the heel. And you can see that the sole of her foot, the plantar aspect of her foot, can rest on my forearm. Now what I'm going to do is grab hold of the heel and I'm going to bring her slowly and gently into dorsiflexion. Now, end of range, okay, so you're looking about 20 degrees is normal for passive dorsiflexion. So I'm either going to feel a bit of a stretch or a restriction at the back, or I might feel some type of restriction at the front. But what I want to feel is a soft end feel rather than an abrupt hard end feel. And I want to make sure that she can go into that 20 degrees. Then what I do is with the opposite leg, so Pauline, if you just bring that one up. Again, fixate the tibia, hands underneath the heel, resting the palm here, and then just bring it there. Now, you could use a goniometer, or you could use an inclinometer as well to measure left v right. Okay, so now we're going to talk about plantar flexion, so where we're bringing the toes away. So again, I'm going to fixate just above the malleolus. So your malleolus is on the end of the fibula here and the end of the tibia here. So fixating just above those. And I'm going to put my other hand on here and passively move the patient into plantar flexion. So one hand fixates above the talocrural joint of the ankle complex. The other hand comes on here like this over the dorsal aspect of the foot. And then what I do is I passively move the ankle into plantar flexion. And again, I'm looking for any pain, any symptoms, looking at the patient if they're going to report anything, and what's the end feel. So the end feel should be, you've got this kind of capsular soft tissue stretch at the front here. What could happen sometimes is that you might pinch some, you might have an ostrogynum or something in the back here that might end up in a pinching sensation. So passive plantar flexion. So now we're going to look at inversion and eversion of the ankle joint complex. Okay, so for demonstration purposes, again, you would have the patient in long sitting, knees fully extended and legs hanging over the bed. So we'll get this foot out of the way. This is just so that you can see what's going on in the video. Again, I need one hand to fixate the tibia and fibula. So I'm going to do it just above the talocrural joint, just above the lateral malleolus. And this time I'm going to bring the plantar surface of the foot in towards midline, which is inversion. Okay? So what I want to do is I'll grab the outside lateral aspect of the foot, and then I will passively invert the foot in like that. For eversion, all I'm going to do, again, I keep the same fixation here. This time I catch the medial aspect of the foot and I'm bringing it away from the midline. So again, catch there. And I'm going to find that again for eversion and dorsiflexion compared to inversion and plantar flexion, I'm going to have about half the range. So I passively evert into that position. Okay, so now we're going to move on to the toes in our examination. Again, the patient is in long sitting, so nothing has changed there. And we're going to use the first raise, so the great toe as an example here. You do exactly the same with the other toes, okay? So again, I'm going to get Pauline to move this leg out of the way just for demonstration purposes. What I want to do with this hand is I want my proximal hand, so the hand that's closest to the patient, or close to the patient's head, is to fixate the midfoot here. So I'm fixating around the first metatarsal here. And then what I'm going to do with the big toe here is bring it all the way into flexion and all the way into extension. The reason why we look at toe flexion and extension, and in particular the first ray or the great toe, is because it's really important in walking gait, running gait, cutting, because you're going to toe off. Okay, so if there's any restrictions in here, then it may have, doesn't have exactly have to have, it may have an effect on the subtalar joint, it may have an effect on the talocrural joint, or anywhere up the kinetic chain just being other parts and aspects of the body. Okay, so that's how we would examine the foot and ankle from a passive range of motion point of view. Hope you enjoyed the video.